So imagine walking into a downtown park at like 2 a.m.
Oh, setting the scene right away.
Yeah, I mean, picture it. You're walking along, and there's a guy lying completely unconscious on a bench.
Right.
He smells super strongly of cheap wine, pants are soiled, and there's this nearly empty bottle just sticking right out of his jacket.
A pretty tragic, but, a fairly common sight in a city.
Exactly. You look at it, and it feels like just a textbook case of a drunk guy sleeping it off, right?
The visual evidence is basically screaming at you to make that assumption, yeah.
But the wild thing is, if you're the paramedic and you just walk away, like, leave him to sleep, well, that man is going to be dead in an hour.
Because the human nervous system, it really doesn't care about the most obvious narrative.
It totally doesn't. And that terrifying razor's edge is exactly what we are exploring for you today on this deep dive.
It's such a high-stakes topic.
It really is. We've been poring over this, honestly, fascinating set of medical board review slides.
The ones from the Sino Medical Association, right?
Yeah, authored by Dr. D. Hamoudi. And these are built to prep medical students for the USMLE exams.
Which, for those who don't know, those are the massive, career-defining licensing exams that doctors have to take.
You can seriously feel the weight of what's at stake in this material.
Oh, absolutely. It's like this intense, concentrated distillation of the absolute worst-case scenarios a physician could ever encounter.
Which is why the visual presentation of these slides is so incredibly jarring.
I mean, the tonal whiplash is real.
It's crazy. Before you even get to the grim realities of these trauma protocols, the title slide has this blindingly bright, cyan-tinted stock photo of a surgeon.
Just beaming at the camera.
Right. And right next to him is this golden caduceus logo with the text, and I kid you not, "You Smile Tutoring and Reviews."
USMILE.
Yeah. It might just be a typo for USMLE, but man, given the sheer gravity of the diagnostic minefields that come after it.
It almost feels like the darkest medical pun imaginable.
Totally. But once you move past that smiling logo, our mission today is really to decode how medical professionals read the human body's most critical warning signs.
Because the overarching theme here is the delicate and often completely counterintuitive nature of the nervous system.
Exactly. We're going to cover everything from the absolute extremes of life or death comas to the dangerous minefield of emergency treatments.
And we'll even get into how severe psychological anxiety can manifest as crippling physical damage.
So we have to begin where the medical protocols demand we begin, the ultimate checkpoint for an unconscious patient.
Right, because before a doctor can solve the mystery of what is causing a symptom, they have to stabilize the patient.
And measure exactly how far gone they are. But the urge to just immediately solve the mystery of the coma is, like, incredibly strong, isn't it?
It is, but the source material enforces a golden rule that overrides all that diagnostic curiosity.
It's capitalized and bolded in the slides.
Yeah, ABC always first before anything else.
Airway, breathing, circulation.
Exactly. And paired with that is the absolute mandate to always assume a C-spine fracture until proven otherwise.
I always think of this protocol like dealing with a completely frozen computer.
Oh, that's a good way to put it.
You know, like you can sit there for hours trying to deduce if a specific software driver crashed.
Right.
Or if the motherboard is fried.
Right.
But none of that matters if the power cord is cut. If there's no oxygen entering the lungs, the neurological software is totally irrelevant.
You have to secure the physical hardware first. Immobilize the neck, secure the airway.
And then, only after the hardware is stable, do the doctors pull out the measuring stick for consciousness, which is the Glasgow Coma Scale, or GCS.
Right. The GCS breaks consciousness down into 3 distinct categories.
You've got eye-opening, which is scored 1 to 4, verbal response scored 1 to 5, and motor response scored 1 to 6.
And you tally those numbers up to dictate the severity of the brain injury. So a score of 13 to 15 is minor.
9 to 12 is moderate, right?
Yeah. And 3 to 8 means you are looking at a severe brain injury.
And the baseline of that scale is, well, it's deeply sobering. The lowest possible score is not a 0.
No, it's a 3. A 1 in each category means no eye opening, no verbal output, and 0 motor response to pain.
The slides also detail some really fascinating pediatric modifications for the GCS, though.
You obviously can't evaluate an infant based on confused conversation.
Right. So for an infant, the verbal response looks for, like, coos and babbles for a perfect 5.
And that descends into irritable cries, then cries to pain, moans to pain, and finally no response.
Okay, let's unpack this for a second, because looking at the scale, it seems so subjective.
How do you mean?
Well, especially the verbal parts. If you're an ER doctor dealing with a patient who is only making incomprehensible sounds,
Right.
how do you reliably score that? One doctor's incomprehensible sound might be another's inappropriate word.
It's true, and the medical field constantly wrestles with that exact tension.
It just feels dangerous when surgical decisions rely on it.
But the text addresses this by placing immense weight on one specific category.
The motor response, right?
Yes. It explicitly states that if a patient is intubated, unconscious, or pre-verbal, the motor response is the single most important part of the scale.
Why does motor response override eye-opening or talking?
Because it bypasses the higher, more complex cognitive functions.
Yeah.
It looks directly at the deepest, most primitive wiring in the brain.
This is like an undeniable physical truth.
Exactly. When higher functions are offline, the truly dire scores, the 3 and the 2, are for abnormal spastic flexion.
Which is decorticate posturing, right?
Yeah, and rigid extensor response, which is decerebrate posturing. These aren't conscious movements at all.
So when you see that decerebrate posturing where the arms and legs rigidly extend in response to pain,
It means the communication pathway between the cerebral hemisphere and the brainstem has been severed or crushed.
wow. So the body isn't even avoiding pain anymore.
No, the higher brain is effectively gone, and you're just watching the isolated primitive reflexes of the brainstem firing blindly.
It's the nervous system stripped down to its absolute bare wiring. Which, honestly, brings us perfectly back to that man in the downtown park.
The real-world case study.
Yeah. The source uses this case to show how doctors use these tools to cut through incredible bias.
So let's examine the scene again. The paramedics find this 50-year-old man comatose on a park bench. He's been there for hours,
And his GCS is a 7.
which puts him squarely in the severe brain injury category.
He scores a 1 for no eye opening, a 2 for unintelligible sounds, and a 4 for non-specific withdrawal movement.
But here's the thing. His vitals are mostly stable. Blood pressure is 140/90, pulse is 90, oxygen is 94%.
Blood sugar is 80, heart is in a normal sinus rhythm. He had noisy breathing, but it cleared up with a simple jaw thrust.
So the monitor says he is stable, but the environmental clues paint a very specific distracting picture.
Right. They find an empty bottle of Thunderbird wine in his jacket and a full bottle of Delanton, dated 2 weeks earlier.
He reeks of alcohol, his pants are urine-stained.
And his friends tell the medics he'd been drinking heavily for days because he had a terrible headache. Oh, and he has encrusted sutures on his right scalp.
If you are an exhausted ER doctor, your brain is wired to recognize patterns, and the pattern here is incredibly loud.
He smells like alcohol. He has the empty bottle. The easiest, most obvious conclusion is that he's just passed out drunk.
The bias pulls you strongly toward just letting him sleep it off in a corner bay.
But the differential diagnosis list for altered consciousness is huge. It includes shock, hypoxia, exogenous toxins, which covers the alcohol.
And major intracranial hemorrhage.
So how do the doctors look past the obvious neon sign pointing to the alcohol?
What's fascinating here is they rely on one vital, undeniable physical finding.
Or pupils?
Yes, his right pupil is 6 millimeters and does not react to light, while his left pupil is 3 millimeters and is reactive.
Asymmetrical pupils.
That single physical detail completely shatters the alcohol narrative. Pupil asymmetry suggests brainstem compromise with herniation.
Okay, let's break down the mechanics of that herniation, because it's horrifying when you realize what's happening inside his head.
The skull is a closed, rigid box. It cannot expand.
Right, and something inside his skull, likely an intracranial hematoma, a pooling bleed, is expanding.
Maybe he bumped his head while drunk a week ago, which explains the old sutures and the recent headache.
But now, that blood is taking up space that doesn't exist. It creates a massive pressure gradient.
The expanding hematoma physically crushes the brain tissue and pushes it downward toward the opening at the base of the skull.
Uncal herniation. And as it's forced downward, it compresses the third cranial nerve, the oculomotor nerve.
Which carries the fibers that tell the pupil to constrict.
So when that nerve is crushed, the signal is blocked, and the right pupil just blows wide open.
The blown right pupil is not caused by the Thunderbird wine. It is an alarm bell that his brainstem is being actively crushed.
The alcohol is just background noise.
Yeah.
The real emergency is the hematoma.
It shifts him from a let him sleep scenario to an immediate trauma surgery activation.
It's a masterclass in trusting the physiology over the environment. But the danger doesn't stop there.
No, it doesn't.
In the case notes, the paramedics gave the man naloxone, and he didn't respond, which is actually a blessing in disguise.
Because the standard emergency interventions for an unconscious patient are a pharmaceutical minefield.
Let's talk about that standard cocktail.
Yeah.
Glucose, thiamine, naloxone, and flumazenol.
The goal is to rapidly reverse common causes of coma, like severe hypoglycemia or a narcotic overdose.
Here's where it gets really interesting. Treating an unconscious patient with these drugs is like throwing a bucket of water on a blazing fire.
Usually it saves the house.
But if you don't realize you're dealing with a grease fire, throwing that water makes the entire room explode.
Let's look at glucose as the ultimate grease fire scenario.
Okay?
Low blood sugar is a probable cause for coma. So the instinct is to push IV glucose to feed the starving brain.
Sounds totally harmless, right?
But giving a massive load of glucose to a malnourished, thiamine-depleted patient like a chronic alcoholic can precipitate Wernicke's encephalopathy.
You can actually plunge the patient into a deeper, irreversible coma.
Yes, because thiamine is the spark plug that allows brain cells to burn glucose for energy.
So if their thiamine reserves are empty and you flood them with glucose,
The metabolic pathway hits a brick wall. The brain shifts to anaerobic metabolism, producing massive amounts of lactic acid.
you're not feeding the brain, you're drowning it in acid and accelerating cell death.
Precisely. That's why the protocol demands 100 milligrams of 5-E thiamine before pushing the glucose. You must install the spark plugs first.
Wow. And the slides also note that if a patient's blood sugar is normal, giving them glucose during a stroke can actually aggravate the brain damage.
The cure literally becomes the poison.
And we see similar risks with naloxone. It's a miracle drug for narcotic overdoses, sure.
But the text warns staff to be prepared. When you give that 2 milligrams the fee, they often wake up violently combative.
Which puts everyone in danger. And if the guy has an expanding hematoma,
Fighting the staff could fatally spike his intracranial pressure.
what about flumazenol? That's
Mhm.
used for benzodiazepine overdoses, right?
Yes, up to 1 milligram for the fee. But the caveat is massive. If the patient ingested a mix of drugs, it can induce severe, uncontrollable seizures.
Wait, why does mixing drugs change the reaction so violently?
Benzodiazepines act as the brain's biological brake pedal. If a patient overdosed on heavy stimulants and benzos, the benzos are the only thing stopping fatal hyperexcitability.
Oh, I see. So if you push flumazenol.
You instantly rip the brake pedal out of a speeding car, the stimulants take over, and the brain violently seizes.
If these treatments are this risky, how do paramedics make these split-second decisions without making things worse?
They rely on strict environmental guardrails, the usual questions for unconscious patients.
Right, because the patient can't speak for themselves, so they ask. How old is the patient? Is there a history of seizures or diabetes?
Exactly how long have they been unresponsive? They meticulously search for bottles like the wine in Delanton.
They check for medical alert bracelets, and they rely heavily on smells.
The smell of bitter almonds might indicate cyanide. Or, if multiple people are unconscious, it points to carbon monoxide.
It requires such extreme discipline to pause and gather that context.
Instead of just aggressively treating the coma.
Right. So we spent this deep dive looking at brains that are shutting down.
Yeah.
But for our final section, we're flipping the script.
We are going to look at a brain that is stuck in absolute overdrive.
Exactly. We're moving into psychiatric emergencies, specifically generalized anxiety disorder, or GAD.
What's striking is that this is in the exact same emergency medical deck as the comas and overdoses.
It really validates how serious it is. The text gives us this case study of Joe. He's a 47-year-old veteran.
Spent 20 years in the ADF, with deployments to Bougainville, the Solomons, and East Timor.
Joe describes this relentless what-if loop. What if I can't find a job? What if I get terribly sick?
And his physical reaction to those thoughts is severe. Tummy upsets, sweating, diarrhea, neck and shoulder pain, headaches.
Those symptoms perfectly match the very first slide of this medical deck.
The general symptoms slide. Fatigue, asthenia, myalgia.
Right. But Joe doesn't have a viral infection. His symptoms are generated entirely by his cognitive state.
His nervous system's response to his own thoughts.
So what does this all mean? Because, look, we all experience anxiety. We all worry about money or get hot flushes.
Sure, it's a normal human emotion.
At what point does Joe's natural worrying cross the line from just being a worrier to a diagnosable medical condition?
If we connect this to the bigger picture, it's about the biological threshold where worry inflicts structural damage.
Hexalen's a very strict criteria, right?
Yes. For 6 months or more, on more days than not, the anxiety has to make everyday activities difficult.
So it isn't just a fleeting reaction. It's half a year of constant interference.
Plus, you need 3 or more physical symptoms. Feeling restless, fatigued, difficulty concentrating, irritable, muscle pain, or trouble sleeping.
The biology behind that muscle pain is wild. Joe's amygdala is perceiving a constant existential threat.
It signals the hypothalamus, which floods his body with adrenaline and cortisol.
His sympathetic nervous system is screaming at his muscles to tense up for a physical fight that never comes.
The tension never releases, lactic acid builds up, and cellular inflammation sets in. It isn't just all in his head.
The physical damage to his muscles and his gut is entirely real,
His cognitive software loop is running so hot that it's literally melting the body's hardware.
proving that psychiatric emergencies are just as physiological as a head injury.
It really brings our exploration today full circle.
It does. We started this deep dive evaluating complete physical unresponsiveness on a park bench.
A life saved by recognizing a single blown pupil.
We navigated the deadly paradoxes of emergency treatments, where a simple dose of sugar can worsen brain damage.
And finally, we saw how an overactive mind can physically break the body down.
It just highlights how incredibly complex and fragile the human nervous system is.
And it leaves us with a really provocative final thought for you to mull over.
What's that?
Well, if a highly trained doctor can look at a comatose man and be completely fooled by the obvious narrative of an empty wine bottle,
Yeah.
how often are we looking at our own severe physical exhaustion or our own muscle pain and entirely misdiagnosing the bottles in our own environment?
Oh, wow.
Are we blaming a lack of sleep or a busy schedule when our nervous system is actually waving a massive red flag that we are completely ignoring?